Next class, right? You all ready for it? For me. I haven't finished making up yet. It'll be very similar to that last test, maybe a little bit shorter. I know a couple of people couldn't get finished earlier. There'll be 45 multiple guess. And last time, what, there was 15 short answer? Probably 10, something like that. Very similar kind of questions as last time. There might be some questions from the previous material. Not a lot. Most of the questions will concentrate on the recent stuff, but of course it builds on itself. All the material keeps building on itself, so you need to remember what we talked about in the first few weeks for this exam as well. But I would say, I don't know, 90% will be new material. I'm guessing something like that. So any major problems in the material we've gone over? Any burning issues? Make sure you know the difference between a GTO and a muscle spindle, what they do differently. What does a muscle spindle do? What does a GTO do? What is the difference between recurrent inhibition and reciprocal inhibition and all those kind of words? Know a stretch reflex, know your reflexes, know your pathways.
Are reciprocal inhibition and autogenic the same?
No.
One turns off the antagonist.
Autogenic inhibition is what?
Which turns off muscle.
Yeah, autogenesis, whatever. Yes, that's who does that? GTO. So the GTO tries to shut down the muscle that came out of, or not out of, it comes from the muscutaneous junction, isn't it? Reciprocal inhibition is what? Yeah, yes. Well, it's a general term. Reciprocal inhibition basically means you inhibit the antagonist when you want to contract the agonist. So it can be the muscle spindle. The muscle spindle does that, or not the muscle spindle, but the spinal cord does that when you do the patellar tendon tap reflex. To allow the extensors to contract, you have to inhibit the flexors, the hamstrings. But also, you get reciprocal inhibition from the top down. When I want to turn on my quads voluntarily, I also shut off my hamstrings. When I want to do a bicep curl, I've got to shut off my triceps. And that's reciprocal inhibition. And that's from a top down does that. So every time you activate one side of the joint, you turn off the other side of the joint. And activation can come from the muscle spindle, or it could come from a pattern of commands coming down from the corticospinal tract. Okay? The exam will cover everything up including, I'm going to finish off talking about cerebellar pathways today, and that will be it. Most of the time today we're talking about cranial nerves. That won't be on the exam. Except for the little bit of cranial nerves I've already mentioned. Like you should know what the names of the cranial nerves are, and you should know one or two facts about each one. You need to know what trigeminal nerve does, muscles, chewing, face sensation. Okay? We're going to go over the details of those pathways and nuclei, etc., next today. But just the basics, a question on the basics of those cranial nerves could be on the exam. But any detailed information today will not be on the exam. Fair enough? Okay, so let's just quick review what we finished off talking about last class. Pressure, simple crude touch. These pathways are different than the fine discriminative touch. Fine discriminative touch, remember that pathway goes up where? The fine or discriminative touch, in other words, to tell what is on my hand, here's the 2 points, how far apart they are, etc., etc. The discrimination of something in my hand is discriminative touch or fine touch. This is simple or crude touch, and pressure, they go up this ventrospinal thalamic tract, okay? Where does the fine discriminative touch go? The what goes up the lateral spinal thalamic tract? Pain and temperature. So where do my fine discriminative touch sensations go up? They go with proprioception, yes, cutaneous, vicus facialis, etc., etc. So this is that simple or pressure and simple crude touch. Remember, this one is this pathway or this sensation is the least likely to be lost with a ground sequoid lesion or any other kind of spinal lesion, spinal cord lesion because of this redundant system going up the ipsilateral side of the cord. So the first order neuron comes on and gives a collateral that goes up and branches off at every other segment above it, basically. Remember though, this does not go, it's not a bilateral tract in that these collaterals here don't carry on and go up to the VPL. Only this side goes up to the VPL. So it's a redundant system, so it's very, you don't typically lose pressure or crude touch with a spinal cord lesion because it's a redundant pathway. I didn't show you this last time I grabbed these. This is Semmes-Winstein monofilaments, very similar to von Frey hairs. You can see, you get a whole rack of them, and you basically, a monofilament, you push them down onto the person's foot or finger, whatever, and there's maps for this, you know, you'll learn a whole map of the hand, where to press and what kind of stuff you need to look at. But for example, the 10 gram monofilament in the Semmes-Winstein, which has a thickness of 5, they're labelled 5.07, and sometimes they've got the grams on there as well. This is the plantar protective sensation cutoff. If you don't feel that, you're in a severe problems of getting ulceration on the foot or not noticing ulcerations. So that's the one you'll use for protective sensation on the plantar surface of the foot. There's other ones you'll use different values for the hand, for example. And these are von Frey hairs, very, very similar. Just, they're all labelled and you pick them out and you go through them. And there's a whole protocol of going through these. You'll learn which one to use first, you know, what to do, etc., etc. You map them on the hand. On the last thing on the bottom there is a 2-point discrimination. You can do, there's various devices that can do that for you, but I mean, there's little pinwheel with little 2 points that come down and you can vary the distance of those points and you can press them on the hand or the foot or whatever and you read off, can you feel this, are the 2 points here, the 1 point. So you can map these sensations out on various parts of the body. And you'll practice doing this, I'm sure, in your clinical courses. So the PTs, have you seen Semmes-Winstein? Not yet, you've done that? Okay, so in OT, have you done it yet? No, you'll do this when you're looking at the hand, for example, particularly the sensation of the hand. Okay, then we got to this mess, the proprioceptive fiber pathways. This pathway here shows the proprioceptive information going to consciousness. Okay, to get a conscious proprioception, you've got to get a somatosensory cortex. And this is the way you do it. You come up, you go up through your nucleus, your fasciculus gracilis or nucleus, fasciculus cuneatus or fasciculus gracilis, up those pathways in the dorsal columns, hit the nucleus gracilis or cuneatus, immediately cross over, ascend in a medial meniscus up to the thalamus, the VPL out to the cortex. So as we've gone over that pathway 1,000 times, that's conscious proprioception. Sometimes it's called a dorsal meniscal system. It goes to the dorsal side of the cord and through the medial meniscus up to the sensory cortex. Okay? But we need to, that proprioceptive fibers come in, splay out, there's many connections at segmental level. Same thing, serum fibers come in touch, going the same way. Vibration also follows this pathway, remember. We've done that. We can have collaterals at the segmental level for reflexes, like your muscle spindle reflex, like your GTO reflex, inverse myotatic and myotatic reflex. But then you also get these spinocerebellar pathways taking information up to the cerebellum. Okay, and we went over these, how the Clark's nucleus come, is the start of the dorsal spinocerebellar tract, goes into the inferior cerebellar peduncle. We have our bilateral tract, okay, the anterior spinocerebellar tract. That comes in leg information, leg proprioception comes in. We have the cuneo-cerebellar tract going from a lateral cunate nucleus for the arm information. Okay, you've got all those down, hopefully. Where they go, what they convey. But basically they all take the information from proprioceptive input into the cerebellum. Okay? Because remember, the cerebellum is a non-conscious process of information. We need to get this information about how our body is, with muscle tone, muscle force, how bent my leg is, etc., etc., to the cerebellum, because this really controls our rapid, non-conscious muscle tone, positioning, muscle coordination, etc., etc. Okay? So this allows, so we're going to go on now and talk about how we get this information back out once it gets into the cerebellar cortex, how this is processed and read out to adjust muscle tone. So, so just to review, we've done this ventral, anterior spinal cerebellar tract, superior cerebellar peduncle, leg information. So you need to know which tract goes from which part of the body. So if I'm looking at arm information, how does arm proprioceptive information get to cerebellum? Which way does it go? What nucleus does it go through? If there's a lesion here, what would I lose? So I could lesion any of these tracts, and you should be able to tell me the patient would have lost proprioceptive information from blah blah, his arm, his leg, his whatever. Okay? So now we get, this is a new slide now. Now we get into the cerebellum. We get all this information through the cerebellar, the ventral spinal cerebellar, and the dorsal spinal cerebellar tract into the cerebellum, into the cerebellar cortex. Okay. The function of this is to allow us to rapidly correct muscle tone, modify actions, etc., etc., without having to go to consciousness. It's done without us being aware of it. Constantly, I'm standing here, muscle tone has been adjusted all the time to keep me balanced. Okay, and one of the things that does that is the cerebellum, and the way that does it, there's various pathways coming out of the cerebellum. One of the most important one is this. You can see here, once you process information in the cortex, remember there's those deep nuclei within the cerebellum that are the output for information processing within the cerebellum. So you process these proprioceptive information within the cerebellar cortex, then you send it out to an output nuclei. Those nuclei deep within the cerebellum then send it to various other sites for tracks that start the tracks down the core. Okay, so it's a relay of information. One of the fastest or one of the most important ways of doing this is this pathway here. Cerebellar cortex, dentate nucleus, that's one output nuclei, then over to the red nucleus. So cerebellar cortex processes the information, sends it to the dentate. The dentate then outputs that out of the cerebellum to the red nucleus. The red nucleus is the start of what? Tract.
Rubospinal.
Rubospinal tract. It's a very rapid way of getting alterations in muscle tone very quickly via the rubospinal tract. We didn't have to go to the cortex. I didn't have to have conscious awareness of that my leg was bending too much. I need to straighten my left leg because I'm leaning over to the left or something like that. It does very rapidly via these rubospinal tract. If you lose these proprioceptive fiber tracts coming up to the cerebellum, what do you think you see, symptom-wise? Ataxia. Clearly. I mean, you don't know where your body's in space. Subconsciously, the cerebellum can't adjust. So you're going to have ataxic issues if you lose these proprioceptive inputs into the cerebellum. Okay? So remember, this information coming up has to be processed by the cerebellum. And if it doesn't get there, the cerebellum cannot adjust muscle tone, can't coordinate muscle actions, and therefore you look ataxic. What's the term, if I lost my fine discriminative touch? What symptom would they present with? What would you call that? If they lose their fine discriminative touch abilities. So this is coming up the dorsal columns. Up now though, it's going to go to consciousness, okay? I cannot consciously perceive tactile information. Right, that's what I'm saying. Fine discriminative touch is gone. I don't know what that is in my hand. I can't determine what thing it is. What would you call that? Agnosia. What type of agnosia? Tactile agnosia. Tactile agnosia. Another term for it is astereognosis. same thing, basically. Is anything in there? Doesn't look like to me. Asterignosis is when you lose tactile information, you do not know what's going on. There must be in there. Stereo. Yeah. Okay? You don't... okay, back to proprioception. If you don't know where your feet are by proprioception, you might look at your feet. They might have a wide base of support during gait. They're not sure where the feet are. Particularly when there's a cluttered environment, the patient will look down at the feet to try and figure out what's going on because they can't feel them. They don't have that conscious awareness or subconscious awareness of where those feet are. So you get ataxic gait. They'll have a positive Romberg sign. Have I mentioned that before? The Romberg sign? What's that? I haven't mentioned that thing. If you lost your proprioception, a positive Romberg sign. That's basically you sway a lot, essentially. You stand with your feet together and they sway. More than normal. The balance looks uneven, basically. If it can be you're swaying, well, there's lots of reasons you might sway, but let's pretend it's just due to proprioceptive issues. Sometimes their sway will not be exaggerated with their eyes open. So if they stand still, they look okay. Maybe a slight increase in sway. But then they close their eyes and they start going all over the place. Why is that?
Because you're lacking the visual input?
Because the vision has replaced proprioception. So I can stand quite well without much proprioception as long as I've got my eyes open. Because vision is so powerful telling me how I'm moving, I can use vision to overcome my loss of proprioception. You take vision away from them, they're in a right mess. You've got the vestibular system as well working, hopefully, but if you've lost your proprioception, you're going to have a marked increase in sway. Okay? If sometimes you open your eyes and you're still swaying a lot, it might be an output issue. Okay, now I've got the proprioceptive information into the cerebellum, but the cerebellum's not working. The pathways like the dentate nucleus, cerebrospinal tract are not working correctly. Now I'm going to sway even though I've got my eyes open. I'm getting correct information in, but the cerebellum is not working properly to correct muscle tone. So it's an output issue. It could be. You can do what's known as a sharpened Romberg. Have I mentioned that one? The sharpened Romberg, or tandem Romberg. You basically put heel to toe. It's much harder for a geriatric patient. You put your heel to toe, feet straight in line with each other, and then they really will sway there. That's called the sharpened or tandem Romberg. It's much harder for your geriatric patients to do than a normal Romberg feet together. There's an interesting disease that attacks proprioceptive neurons in the dorsal root ganglion only. It's a disease that for some reason selectively attacks the dorsal root ganglion proprioceptive neurons, and you get attacks as a result of this. Any idea what that disease is? Syphilis. Which hopefully none of you, well, haven't had. So yeah, that was a big issue a while ago, in the Middle Ages, syphilis, because there was no cure for it. And the syphilis that gets in, neurosyphilis gets into the brain eventually and can kill them. But in the initial symptoms, it destroys these proprioceptive neurons in the dorsal ganglion for some reason. It eats those away, and the patient has an ataxic gait. Fortunately now it's pretty simple to cure it. What do you have? What did I have when I had it last then? What's the cure for syphilis? Penicillin, right? Penicillin. Now that knocks it out very quickly if you enough dosage of it. Which was invented or discovered when? 40s, yeah. Who discovered it? Bit of trivia when it found me on Jeopardy. Who discovered penicillin? An English bloke, right? It's Alexander Fleming. Remember him? No, you've heard of that? This, the story where he left the petri dish open overnight and the bacteria grew, but the fungus had killed the ones that killed the bacteria with fungus. So he did it. He got a Nobel Prize in 1945 for this work, along with Florian Chain, who actually synthesized it. Why was that so important then, in the 40s?
The war.
The war, Second World War, saved many, many people because of penicillin. I can tell you a funny story about the original. I'll tell you later, perhaps if we have time. Funny story about what was the original cure, original treatment for syphilis. I'll tell you. Well, just an aside for fun. So we'll get back to this mess. It was mercury paste. The doctor would made a paste out of mercury and would smear it on the lesions on the arm or wherever it came. And of course it didn't work, did it? It made the patient worse. The old term for mercury was quicksilver or quacksalver. So the person who prescribed this mercury-based paste was called a quack. And that's why a bad doctor now is called a quack. Because of the old days, he put this mercury paste on the lesions and it made the person worse, it wouldn't work. So the old sort of saying in the medieval days was, 1 night with Venus, 6 months with Mercury. So you'd have this paste on for 6 months to try to get rid of it, and it didn't work, of course. So fortunately there's penicillin for those people. Anyway, I'm not telling a story about that, but well. So, proprioceptive fibers into the cerebellum. Cerebellum is the processor of this non-conscious proprioceptive information. It reads it out various ways. One of the ways we talked about was this dentate nucleus, red nucleus, rubospinal tract. But you can see here, there's many other ways that the cerebellum can output information down to the spinal cord. Let's talk about some of those pathways now then. The cerebellum, remember, receives a lot of information from all around the body. It is the non-conscious processing of this postural adjustment. So it receives, besides proprioceptive information, it receives a ton of vestibular information. A lot of the vestibular tracts coming out of the vestibular spinal, the vestibular nuclei go to the cerebellum. A whole chunk, remember, the cerebellum is devoted to the vestibular information, the focio-nodular lobe, or the vestibular cerebellum. Yeah, it's not shown there. So we get proprioceptive input into the cerebellum, we get vestibular input into the cerebellum, we get visual input into the cerebellum, we get auditory input into the cerebellum, we also get efferent copies or efferent copies pouring into the cerebellum. What are they? So all our sensory information, mainly, predominantly proprioception, vestibular information goes to the cerebellar cortex. But we also get efferent copies go to the cerebellar cortex. What are they for? What are efferent copies? They are copies of what we tell the body to do. So, you can, is it on there? No. When we tell my body to pick up a weight, do anything, we send a copy of that command to the cerebellum. So the cerebellum knows what your body's going to be told to do. The cerebellum knows where the arm is in space. My arm is bent over here, and my head is spinning, or I'm leaning this way. So it coordinates that muscle activity to allow us to rapidly adjust for unexpected sensory consequences. like when you pick up a jug you think was full of milk and it's not. Okay? So we need to know what the body's been told to do to be able to quickly adjust the goal, the aim of this movement. Just remember when you poke yourself in the eye. Remember we did that thing, you poke yourself in the eye, the world moves, doesn't it? But if I move my eyeballs left and right, the world does not move. Because I sent a command to my brains, to my cerebellum, saying, you're about to move your eyeballs, cancel out any movement of the images on the retina, because that's the eyeball moving, not your face is moving across my retina. So it's a very important integrator of all this information to allow us to control movements and predict what we're going to be doing with that movements. And I've kind of summarized some of these pathways. So these are some of the important pathways for the vestibular system into how the vestibular system can rapidly affect the cerebellum and therefore the body when I move my head or when I feel myself falling over. Okay? You can see the vestibular apparatus, we're going to talk about that soon, send information to the vestibular nuclei. I can post this diagram if you like, it's just pretty simple. But here it is, you can see the vestibular information coming from the vestibular nuclei out to the cerebellar cortex. Okay? So we get vestibular information about how my head is moving in space. Am I falling forward? Am I leaning back? Am I spinning? Am I translating left and right? Okay? The vestibular nuclei receive the information and you can see pass it rapidly on to the floccular lobe, which is the vestibular cerebellum. We process it. We output it via the vestigial nucleus, not the dentate going to the cerebrospinal, it's the vestigial nucleus, which then passes it on to the reticular formation, reticular area, which of course is the start of the reticular spinal tracts. This is the feedback loop or through the cerebellum of vestibular information. We also, the vestibular nuclei are start of the vestibular spinal tract. You can influence the vestibular spinal tract without going to the cerebellum. Okay, vestibular nuclei start the vestibular spinal tract. We'll talk about that tract. We'll look at the vestibular system later. So you can see these two pathways, vestibular spinal and reticular spinal, influencing muscle tone, muscle coordination as a result of head movement. Okay? This works alongside the cerebrospinal tract, which influences the body based on proprioceptive information via the dentate nucleus. Okay? So the cerebellum is very important in processing vestibular information, processing proprioceptive information. The last thing we'll talk about later, but I'll put this arrow on here. What is this here? What's this? Why have I put this arrow? What is all this about? I'm going to get to that when we talk about vestibular system, but what are vestibular ocular connections for? There's pathways emanating from the vestibular nuclei, vestibular ocular pathways. What are they for? Where do they go? Any guess? Ocular means eyes. They go to the cranial nerves that supply the eyeball, which are what? Name the three nerves that go to the eyeball. Cranial nerves that supply extrinsic muscles of the eye. What are they? Oculomotor, abducens, and trochlea. Why do you want to send vestibular information to the eyes? Because when I move my head, I want to fix my eyes. I want to control my eyes as a function of head movement. When I turn my head, we talk about detail in the vestibular system, but when I turn my head like this, my eyeballs aren't just doing this. If I do, I can make them do that. All I see is a blur. That's completely worthless to me. So what you do, of course, when you turn your head, and when I turn my head to the left, My eyeballs go to the right. They fixate on something, and then they jump over here, turn my head, they jump. Yes, saccade, they jump quickly and fixate. Head turns, jump. So every time you turn your head, your eyeballs are turning the opposite way. Maintain fixation on an object. You do not want your eyeballs to track across the space like that, because you just get a blurred image, which is completely worthless to you. So the vestibulo-ocular connections are responsible for keeping your eyes fixed on an object when you turn your head, amongst other things. And we'll talk about a lot about that later when we talk about the vestibular system. Okay, so name me 8 symptoms of of cerebellar damage. What are they? Just throw some out. I don't know, it could be 10, 15, whatever. Nystagmus, right? Nystagmus. What's nystagmus? Eyes rapidly twitching, left and right, left and right. Slow one way, quick the other way, typically. Nystagmus. Damage to the vestibular system. Cerebellum, yes. What else? Dysmetria, what's that? Past pointing. That's not inability to do rapid pronation, supination. That's not that. Which is what? Dysdiadokinesia or adiadokinesia. They can't do this thing. What else? Falls. Ataxia. What else? Come on. If I have a question asking for 10 symptoms, what else?
They're not paralyzed.
They're not paralyzed, yes. Yeah, that's hardly a symptom. They're not dead, yes. Okay. They're breathing, yes. That's another, I won't say they were symptoms, but what else? Are they hyper or hypotonic? Typically. Hypo, typically. Not always, you can find hyper, but typically it's hypo. They will fall to the side of the lesion if you're walking, or they'll lean to the side of the lesion. Okay? Unlike cerebral lesions, cerebral lesions, you do the opposite. Cerebral lesions, remember, you're going to fall to the side of the lesion, typically. Cerebellar, you kind of go to the side of the lesion. What else have we got? Intention tremor. Right? Intention tremor versus resting tremor. Which one? Intention tremor. Resting tremor associated with Parkinson's disease, amongst other things. You'll find sometimes I've mentioned dysphonia. This is slurred speech. Dysphonia. What's dysarthria?
Problems with articulation.
Problems with articulation, problems with speaking, but not due to a central processing issue. Okay? You might find sometimes what's known as scanning speech. Irregular spaces in the words, so they'll kind of talk like a robot and go faster and slower and then quickly speed up and then stop, and kind of really weird spacing between their words. Anything else you can think of? The trouble with having these symptoms we just mentioned, quite a few of these could either be cerebellar or vestibular damage, couldn't they? Which of these symptoms we mentioned could be a symptom of both cerebellar and vestibular system?
Any of the balance issues?
Any balance issue. Ataxia. I could walk in a drunken kind of pattern because my balance is off because of my could be cerebellar damage, but it could quite easily be vestibular damage. What else? So Romberg sign, you don't know, it could be either. What else? Nystagmus. Eye twitching can be caused by cerebellar damage, can be caused by vestibular damage. You would not find dysmetria and dysdiadokinesia with vestibular damage typically. So there's some symptoms that are only exhibited by cerebellar damage but not vestibular damage. So a patient coming in to see you has got poor balance and ataxia, you don't know what it is until you start doing, history and examination. So be careful you don't confuse cerebellar issues with vestibular issues, because they can mimic each other quite easily. Cerebellar damage, trauma, strokes are typical. The biggest issue probably in adults is going to be some trauma or some stroke issues in the cerebellum. In kids, unfortunately, you get this one. If you know blastoma, that is the most common problem in kids in terms of damage to cerebellum. I think nearly all the brain, not nearly all, but I think 60% of brain tumours in children are this. I think, something like that, I'll quote me on that, but it's unfortunately quite common between 4 to 8 years old. Very rarely we see in these adults. This is a very nasty tumour to get, very aggressive, and it occurs, you can see here, usually behind the fourth ventricle, here on the cerebellum, right in here. It grows very rapidly. Unfortunately, I had one child with this at Eastern Maine, a sad case. Prognosis is very poor. They'll try to resect it, and basically shown here, this is it on the top right there. They'll go in there and try and cut as much of it out as you can. And then, chemotherapy, radiation therapy. It is radiosensitive, the tumour. Males get it more than females, but I think many kids will die within a year of having this. And I think though the stats go 60% survival for 5 years. So 60% of the kids who get this will survive for 5 years. But that's after that it's pretty bad. I mean, it grows very rapidly. It gets into cerebrospinal fluid and it metastasizes throughout the nervous system. The first thing you'll see in your children who've got this, they'll stumble probably. They have ataxia and they'll fall when they're walking. They look like they're drunk when they're trying to walk. And it's a very nasty thing to get. And I knew the history of this, and the parents came in and asking me, what's the prognosis, but the doctor wouldn't tell them at that time. He wasn't sure what was going on, but it was obvious what it was. And they're not really sure what tissue it is, to be honest. They're not sure what is causing this. It's their cells they've tried to isolate. It might be cerebellar stem cells, but we're not really sure why it occurs. And as I said, the treatment is tough for a kid. They're going to go in there and try to dissect as much out, and then radiotherapy, chemotherapy, and they're going to die in a few years, even with that kind of stuff, unfortunately. It's a pretty nasty thing to get. Okay, let's move on. So we've talked about all these pathways throughout the body going to the cortex or going to the cerebellum. But we've only mentioned body, sort of neck down information. What about the head? What about the face? We get our trigeminal nerve. So this is a segue into our cranial nerves. Sensory pathways from the face. It is not the facial nerve. It is the trigeminal nerve, cranial nerve 5. It's responsible for all those sensations we've talked about: proprioception, pain, temperature, pressure, vibration, blah blah blah. All those ones we've talked about from the body. It's the trigeminal nerve responsible for this once we get above the neck, kind of thing. And we'll come back to this when we look at the motor components of this, but there are 3 major branches of the trigeminal nerve. these three here. Ophthalmic, with a PH, maxillary, and mandibular. Basically naming the place where they go. Ophthalmic, maxillary, and mandibular. Sometimes just called V1 or 5-1, V1, V2, V3. 1 at top, 2 middle, 3 bottom. V, remember, 5 is trigeminal cranial nerve, 5 is trigeminal. So V1, V2, V3 are the three branches of the trigeminal nerve. So all the face, the tongue, sensate, not taste, of course. The taste of the tongue is what cranial nerve? What two cranial nerves supply the taste buds of the tongue? Well, I'll leave you to look that up. You might be on the exam. Facial and glossopharyngeal. You knew that, didn't you? Okay, so we're not talking about that. We're talking about other sensations from the tongue, like pressure on the tongue, for example, is going to be the trigeminal nerve. Okay, the cornea over the eye is going to be the trigeminal nerve. The sinuses, the whole face is going to be trigeminal nerve, not facial nerve. Okay, we have a sensory dissociation though in the trigeminal nerve, just as we do in various parts of the body. In other words, different senses go different pathways. Let's look at pain and temperature. Pain and temperature from the face. So I stick a pin in somebody's cheek. How do I consciously perceive that pin prick? Okay, his pain. Or how do I consciously perceive temperature? It goes down these black lines. The cell body of these unipolar neurons is going to be in this semilunar ganglion, half-moon shaped ganglion. Okay, that is equivalent of what in the spinal nerves?
The dorsal root ganglion.
Dorsal root ganglion, exactly the same thing. The ganglion sitting outside the brainstem. So pain goes down that black line, cell body, semilunar ganglion. The first order neuron carries on though, goes down and ends on this thing here. The descending nucleus of a trigeminal nerve. A long nucleus that goes down pons medulla area. You can see it here, this red line here. This is the descending nucleus. Big strip, not one location. Okay? So you've got the nucleus, you've got the sensation into, it's equivalent of whatever the dorsal great horn, whatever, something like that, in the spinal nerves. Second order neuron takes over, crosses the midline in the brainstem, and ascends in the trigeminal lemniscus. This pathway going up to the brainstem, okay, and ends at the VPM. All of the stuff we talked about in the body ended where? What nucleus within the thalamus? VPL, ventral posterior lateral. This is a ventral posterior medial effect. It ends on the contralateral thalamus, the opposite side from where it came in. It then goes out on a third order neuron, just like all the rest of the stuff we talked about, projection neuron out to the side of sensory cortex. Whereabouts on that sensory cortex do you find the facial information going, roughly? Top, middle, bottom? Middle to bottom area, right? Down here, roughly. Somewhere like here, right? What artery supplies this part of my brain? Posterior, middle, or anterior? Which one? Middle cerebral artery supplies this chunk here, basically, right? With that area. Anterior cerebral artery down the middle and the top. Remember that homunculus of the bloke with his feet hanging in the crack in the longitudinal fissure and his body coming out like that? You can remember where that location is. If you affect the anterior cerebral artery, you're going to affect legs, aren't you? Middle cerebral artery over here, hands, face, arm stuff. Remember that? Okay, so that's how we get pain and temperature from the right cheek to my left somatosensory cortex. Okay? The other sensations, pressure and touch, go a different way. So that is represented by this green line. I went over it kind of thing. That green line. So I'm going to push now on my right cheek. Pressure on my right cheek. How is that felt? First order neuron. Cell body. Semilunar ganglion. Just like pain and temperature. Okay? But then that first order neuron does not go to the descending nucleus. It goes to what's known as the main sensory nucleus. The main sensory nucleus. It's in one location. Okay? That main sensory is ipsilateral. Okay, to the side it came in obviously. But then what happens? You can see my sort of crude representation, my green lines coming up there. It splits. There's a bilateral tract coming out of the main sensory nucleus on the right hand side, as yet on the left hand side, whatever, of course. So in other words, the pressure and touch information is sent to both trigeminal lemnisci, not just the contralateral side. It's not a cross tract, it's a bilateral tract. It then goes up to the VPM, and then VPM out to the cortex, same as the other pathway. So the crucial difference here then is pain and temperature is a contralateral pathway, contralateral projection. Touch, pressure is a bilateral projection. So, if I had a left middle cerebral artery lesion, what would I lose? And from where? In terms of facial sensation. I have a left middle cerebral artery lesion, stroke, whatever. What sensation would I lose and where from?
Pain and temperature from your right side?
Pain and temperature from the right hand side of my face. Exactly. Why wouldn't I lose pressure from the right hand side of the face? Because it also goes to the right cortex. It goes to the left cortex, I lose that, but it goes to the right cortex as well. Therefore, that is preserved. I would not lose pressure and touch information from the right side of my face with a left stroke. And you'll see that in your patients all the time. If you get a patient with stroke in the face, you can see this issue. Test pain and temperature. Test. Okay? So that leads us to our cranial nerves. Proper. So we're going to do a lot more detailed information about these cranial nerves. It's not on the test. No. Do you want to have a test or not?
No.
Whatever. But those pathways, cerebral information on the exam, fair enough, we've done that, it's easy. You all know what this adiacokinesia is, don't you? So it'd be an easy question if I asked you what that was. Okay, so, well that'll be on, but not this stuff. Not the sensory pathways in the face. Okay, cranial nerves. 12 of them, right? 12 cranial nerves. You all know the names of them. You all know the numbers of them. 1 to 12, Roman numerals. You should know the names. You should know the numbers, and you should know, so far we should know 1 or 2 facts about each cranial nerve. Now we're going to go over each cranial nerve in a little more detail, figuring out where it starts, where it stops, the pathways, what happens if you damage one. Okay? You can divide, and you'll see this in different texts, unfortunately, but basically most texts try to divide cranial nerves into 3 functional groups. We have our pure sensory cranial nerves. And nobody will argue about which those are. Pure sensory, what are they? We have 3 of them. What are they?
Optic, olfactory.
Sight, optic, olfactory, smell, vestibulocochlear. Balance, sound. So those are your pure sensory. There's no motor component. You can't contract your retina. Okay? You can't. When you twitch your nose, you're not twitching your olfactory bulb. You can't have any motor fibers in those whatsoever. Then we have 4 pure motor nerves: trochlear, abducens, accessory, and hypoglossal. Okay? And you will find some texts have other ones in there because they have parasympathetic fibers. I'll talk about it in a second. Then we've got our mixed nerves. Our mixed nerves. So we've got more than one, more than sensory or more than just motor. Here, of course, we've got ocular motor, our trigeminal, our facial, glossopharyngeal, and vagus nerves. Okay? All of those have parasympathetic fibers within them, except for which one? The trigeminal. All those have parasympathetic fibers within them, as well as other issues, other things, except for trigeminal. So sometimes you'll see ocular motor, for example, included as a motor nerve. Because it has skeletal fibers and parasympathetic, but the parasympathetic are motor. So it depends what text you're looking at, what they count as a mixed versus a motor nerve. So watch out for that. Are they counting parasympathetic fibers, motor fibers as motor, or are they count it as a mixed nerve because it has parasympathetic and skeletal fibers? We'll get to that in a second. It's pretty obvious. Alright, let's look at the simplest first, work our way into this. The trochlea. We'll look at our small, relatively small motor nerves first. They're fairly simple enough. Okay, the trochlear nerve. So there's a listing there. Look of the what I've called the motor, mixed, and sensory nerves. Okay, trochlear nerve. It's probably the smallest of our cranial nerves. Very small. Innervates one muscle of the eyeball, doesn't it? Which is the superior oblique, which is responsible for doing what to the eye? Moving the eye down. Okay. We find a nucleus within the midbrain. It comes out the back of the brainstem. Beneath what?
The corpora quadrigemina.
Corpora quadrigemina. And the corpora quadrigemina is made up of what? 2 things.
Inferior and superior.
Inferior and superior colliculi. Remember that picture that's coming right out the back there? And what gland sits just above them, those corpora quadrigemina?
Pineal gland.
The pineal gland, okay? So the most common lesion to the trochlear nerve would be what? Paranose syndrome, right? Paranose syndrome. Where the pineal gland has a tumour, swells up, pushes on the superior colliculi, pushes on the inferior colliculi, and eventually pushes on the trochlear nerve. So you get vertical gaze palsy. Remember that Paranose syndrome? Vertical gaze palsy, you can't move the eyes downward easily, and therefore they look down when they look at a cluttered environment or going upstairs. They use the head rather than the eyeball to glance downwards. What else do you see with Paranose besides vertical gaze palsy?
The reactions to light and sound.
No reactions to light and sound, yeah. So particularly for the eye, the pupil's unreactive to light. And so superior click line mediates the shutting down the pupil, changing the size of the pupil with light shining into it. And it does not do that if the superior click line is damaged due to pineal gland tumour. Trochlear nerve affects the movement of the eyeball up and down. Do you know all the muscles of the eye? Have you done that? Have you done that in class? You don't know? Let's just quickly review them because we're going to look at abducens and oculomotor. So these are the directions of. Okay, yeah, this is probably not a good diagram. Well, maybe it is. The arrows in this case show the movement of the eyeball for those various muscles. It doesn't show where the muscle is. It does on the lateral medial rectus. So, 6 muscles of the eye, extrinsic muscles of the eye. Medial rectus on the inside, lateral rectus on the outside, superior rectus at the top, inferior rectus at the bottom. And they just pull the eyeball those ways, obviously. But we also have an inferior and a superior oblique muscle. Okay? All of these muscles are innervated by the oculomotor nerve, except for which two? Trochlear goes to superior oblique, and what's the other one? Which muscle is not innervated by the oculomotor nerve? Lateral rectus, which is abducens. So that's a picture of. I've got lots of pictures. I don't know which one. You look at all these. You can see the superior oblique on the top of the eye goes to a little pulley. So that's why it tilts the eyeball down. Even though it's at the top of the eye, the superior oblique muscle goes to a little pulley and goes to the back of the eye. So it lifts the eyeball up at the back but tilts the eyeball down. So this again shows the direction of the muscles and which way those muscles will pull the eye. Let's look at abducens nerve. Abducens nerve. Simple nerve, not very involved, innervates the lateral rectus muscle of the eye. The nucleus is in the pons, deep down in the pons. Yeah, which picture show? Whatever. Shows there. You can see the nucleus, the bottom one here. Lateral rectus muscle of the eye. This is probably the most damaged nerve of our eye nerves, our cranial nerves going to the eye. You find the abducens damaged more here. It's got a long course. It kind of gets damaged more often than the others. Because it's long course. If you damage the lateral this nerve, what would you see? If I damage my right abducens nerve, what symptom would the patient present with? Inability to turn the eyeball outwards on the right hand side, yes. What else would you see? So you couldn't track my finger across midline. So you can test, when you, in other classes you'll go over how to test all these cranial nerves, but essentially with the oculomotor, these eyeball muscles, you just basically do this kind of stuff with them. Track my eye, when can you see, all this kind of stuff. Follow my finger, and you're testing all the eyeball muscles essentially. So you couldn't track this way over here with this right eye, but what would you see at rest as well? Medial strabismus, medial squint, because unopposed action of the oculomotor nerve. The medial rectus will pull the eyeball in. This patient, obviously on her left hand side, has abducens nerve injury. Contrast that to the oculomotor paralysis on the patient's right eye on the top figure, because now the lateral rectus is working but not the medial rectus. Does that make sense? The bottom patient there, you can see her left eye is going to the midline, medial squint, medial strabismus, because the lateral rectus, the abducens nerve, is damaged. The patient on the right hand side, her right eye has gone outwards because the lateral rectus is working, but the medial rectus is not, because of optic nerve damage. Make sense? So you can see these squints, these strabismi, as a result of unopposed action of various nerves, of various muscles. Okay? Moving on. Let's just finish these few motor nerves. Accessory nerve, fairly simple. The first nerve you found in dissection, right? Innervates two important muscles outside of the head. SCM and trapezius. Okay? In fact, what you'll see, this nerve is actually a displaced loop of the cranial, of the cervical plexus. So in other words, those cervical rootlets come out of the neck and go up to join the cranial portion of the accessory nerve and come back out as the accessory nerve. That makes sense? So even though it's a cranial nerve, those actual neural fibers actually came out of the cervical area and have gone up, joined the cranial nerve, and then come back out to go to the SCM and trapezius. Okay? The cranial nerve portion proper, that comes out the brainstem here, goes to some muscles in the pharynx and larynx and soft palate. So the pharynx and larynx have an accessory nerve supply, and therefore one of the nerves that mediates swallowing. Many of our cranial nerves, a lot of cranial nerves go to the throat, unfortunately, in terms of learning. And a lot of cranial nerves can influence swallowing. So what you find if you've damaged the accessory nerve in terms of trapezius and sternocleidomastoid, what would you see? I've damaged my right one, let's say. My right accessory nerve, what would you see? What couldn't the patient do? What does my right SCM do? Turn the head to the right? What does it do? Anatomy, right? Forgot already. If I turn my right SCM on, it's going to turn my head to the left, isn't it? You can feel it. And side bend to the right. Torticollis, remember? Remember the torticollis spasm of that nerve, that muscle? It's going to turn flex to the right, side bend to the left. That's the SCM job. Bilaterally, they'll do what? Put the chin to your chest, flex the neck. Or if you fixate the head with your extends to the back of the neck, what does the SCM do then? What's the reverse action of the SCM? Kevin? Breathing, right? That's what you're doing it. You just, if you do that, you can feel SCM, come on. Sniffing in, quick breathe. It grabs hold of your rib cage and yanks it up. Expands the rib cage. That's reverse action of sternocleidomastoid. Okay? Obvious biggest problem you'll see in kids, torticollis, wry neck, spasms, problems in that nerve, and the kid's stuck like this. That's a common question in boards. How to stretch a patient with left SCM torticollis. So left SCM. Okay? You're going to side bend to the right and twist the left, wouldn't you? That's a trick question that I've seen before in the boards. What is the SCM action? Traps. What do you do there? Damage traps, what will you see? Can't shrug the shoulders, have difficulty rotating the scapula. If it's chronic, you'll see a patient looking like this in the back. So this would be a normal patient sort of thing. Like that. Slight exaggeration, perhaps. You have this L-shaped one, this sort of triangular neck portion coming in here. Very obvious, this is going to atrophy of the traps muscle. You see this pattern here rather than sort of a normal sloped neck pattern kind of thing. Accessory nerve. Hypoglossal. Simple motor nerve. It's the most inferior of our cranial nerves, right? It comes out down the medulla. Nucleus is the medulla. Start of it is in the medulla. Do you mean when I say the nucleus of the hypoglossal nerve? What do I mean by that? What do I mean by the nucleus of the hypoglossal nerve? Or the nucleus of the abducens? What do I mean by that? What am I saying? You sort of write down, whatever. I'll memorise that for the test, but I've no idea what it means. What am I saying by the nucleus of a hypoglossal nerve? What is it equivalent of in the spinal cord? The ventral grey horn, right? This is where our motor nerves start. Our motor nerves for our biceps start in the ventral grey horn, don't they, right? The big cluster of motor neurons. These nuclei, what I'm talking about when I say a nuclei with a cranial nerve, that's either where it starts or stops. In this case, it's where it starts. Our motor nerve, the cell bodies of the hypoglossal nerve start in this hypoglossal nucleus, which was in the medulla. The hypoglossal nerve goes to all the muscles of the tongue. It does not do taste. It just moves the tongue. Okay? If the nerve is damaged, you ask your patient to stick their tongue out at you. Okay? You've got one tongue, right, typically, but you've got two hypoglossal nerves. One goes to the left, one goes to the right. Okay? You ask the patient to stick your tongue out at you, you get unopposed action. If I've got a right hypoglossal nerve damage, the tongue will deviate to the right. Because there's no muscles on the right hand side pushing. The left hand side muscles push and the tongue goes to the right. Okay? Fair enough? So the tongue will deviate to the side of the lesion when you push your tongue out. What else will you see? Symptoms of a patient who can't move a tongue well.
Dysphagia? Dysphagia?
Would it be dysphagia or would it be dysarthria? What would you say? Dysarthria. It's not a processing issue, is it? It's not a central brain processing in terms of language, but they won't be able to speak properly because their tongue is half paralysed on one side. It'd be like talking marble in the mouth. Okay? Swallowing, chewing. You can't manipulate your food in your mouth. Therefore you have a hard time moving your food around and getting it back in your throat to swallow if you've got hypoglossal nerve damage. So a lot of these nerves, unfortunately, you have to figure out what's going on because you can have problems with swallowing, problems with speech for many, many causes. Last thing, there's a patient who's had long-term lesion to his left hypoglossal nerve. And what happens, of course, because you've lost the nerve, the motor nerve going to the muscle atrophies, and you get these ridges in it, furrows, in this case in his left-hand side, because the muscles just atrophying away. If you stuck his tongue out, you can see it there slightly, it's deviating to his left-hand side, isn't it? The tip of his tongue has gone to the left because the muscles on his left-hand side are not pushing, so the right-hand side muscles push around the other side. Alright, had enough? Me too. Next we'll look at our mixed cranial nerves. We'll do that on Wednesday after the short test.
Yeah.